Good evening, everybody. Namaskar, CCI. Namaskar, India. My close friend NH Krishna, someone whom I love from core of my heart. The expert panelists who are present today. Ashish Bhai, the president. Anil Bhai, the secretary general. And of course, Cipla, the educational partner for today's program. Today we're going to be talking about one of the most neglected, one of the most misunderstood, one of the most underdiagnosed disease. And yes, your and my bread butter disease, and that is COPD. Somehow, COPD has always carried this stigma, as if it is punishment for smoking, as if it's a kind of somehow your respiratory karma. But the truth is, COPD is not only about smokers. We see it in non-smokers also. We see it in women who are exposed to biomass fuel. We see it in people breathing polluted city air. We see it in workers in dusty industrial areas. And yes, even in people who have simply long lived enough to collect this wisdom of bad air. So it's not your sin, it's your disease. And one that deserves your and mine attention. And the irony is, disease hides itself. The lungs have got enormous reserve, and so that patients are fine until almost 50-60% of their lung functions are compromised. And so then when we ask them to do their spirometry or test or investigate, they said, oh, they're feeling fine. Why test someone who's not even complaining? And that's how millions are missed. Across the globe, we've realized that millions of patients, actually exactly double the number of patients that are diagnosed, are missing. That means if you have diagnosed 10 patients in an area, at least 10 patients are yet to be diagnosed. You're already suffering from COPD. And the numbers are frightening. I was making, Vijay, I was making very rough calculations. I looked at the paper which talks about 3.5 billion deaths globally because of single disease COPD. 3.5 million, yani simple calculation karo, 35 lakhs. If it is 35 lakhs patients, you divide by 365 and divide by 24 and divide by 60, you will come to a figure of 6 deaths. Trust me, 6 deaths every minute because of disease COPD occurring globally. By the time we finish our discussion today, 60 people would have died somewhere across the globe silently because of disease. And imagine so many significant number of patients with compromised quality of life because of disease. Pollution, lifestyle bolo, poor ventilation bolo, industrial exposure bolo, yeah, your weak immunity, call it whatever, but suffering is real. One simple test, the most reliable test that we've studied right from our physiology days in first year of medicine, the test which is reproducible, test which has a potential to diagnose disease relatively early. Yes, your good old PFT still remains underutilized. So, friends, today, let's begin this conversation. Let's have this discussion where we talk about the past, the present, and the future. Let's learn from past insights. Let's look at the present practices, and let's look at the future directions that we have with this simple test, spirometry, especially in the management of COPD. So let's talk about how a simple test help you not only to diagnose, but also to guide you in treatment and monitoring disease and even prognosticating the disease COPD. And it's the time where I invite Dr. Chhabra sir, my favorite Dr. Chhabra sir. I express my inability to introduce him. I have to thank CCI for giving me chance to connect with him. First ever I got chance to speak to sir or connect to sir was because of CCI. Though I'd heard about him earlier, his great contribution to science and of course pulmonology, but chance was by CCI. And then I got closer to him when we had a couple of meetings together when he traveled to Mumbai for CCI Con. And I get amazed by his simplicity and his vast knowledge. CCI is aware about his wisdom. So whenever there is any interesting case going on any of the CCI platforms, Dr. Chhabra's comments are really most awaited. PFT is his favorite topic and he's got original contribution to this subject. So friends, allow me to present one of the best brains in pulmonology, one of the best brain in CCI, one of the great teacher and a perfect mentor, none other than Dr. Chhabra. Over to you, sir.
Good evening. Today we are discussing a very important topic and a very focused topic, that is evolution of PFTs in COPD. Now, when you talk of PFTs, there are numerous PFTs that can be done in COPD. But when we order a PFT, then we should know why we are ordering a test, what test we are ordering, how it is going to change the management, and how to interpret the test. Again, the test that we select should be one which is an established test, which has gone through the scientific evaluation of its validity. So its sensitivity, specificity, everything has been worked out, and it's an accepted PFT all over the world. Because during evolution of PFTs, so many tests have come and gone. They have been introduced with a lot of hope, but they didn't survive. So those which have survived, we must know those PFTs and how things are changing. Even the established tests like spirometry, it has undergone a lot of evolution in last 8 or 10 years, especially. So with that background, let me move on. When we talk of lung function, then there is a lot that can be examined in a patient, right from control of breathing to different tests for lung mechanics, gas diffusion, pulmonary circulation, exercise tests, biomarkers, gas exchange. So a whole lot of tests are available, and a good lung function laboratory should have these facilities. It's very, very difficult to have these facilities in a primary or secondary care center, but tertiary care centers, especially those which are involved in research in PFTs, should have these facilities available. Specifically, when we talk about COPD, then it's mainly the lung mechanics that is being tested. The most important test, and which has been tested for last 5 decades, a lot of literature is available. All the drug trials and management strategies are based around spirometry. So we can also measure airway resistance, lung volumes, bronchial challenge tests, body plethysmography. Then there are tests of areas like impulse oscillometry, muscle function, diaphragmatic testing. So these tests are possible, and they give information about different aspects of lung mechanics. But spirometry remains the gold standard test for evaluation of COPD. Now, the tests which we do, they are actually contained in the definition of COPD. In 2025, if we look at the definition, then I have just highlighted the important components besides that it's a chronic disease with symptoms: abnormalities of airways, bronchitis, bronchiolitis. Now, this is a very, very important component. Bronchiolitis is small airways disease, and it is universal in COPD. All patients of COPD will have bronchiolitis. That is where the disease starts. Emphysema. A lot of patients do have emphysema, which may or may not be radiologically evident. And then the third line, that it causes persistent, often progressive airflow obstruction. Now, this is the operative part of the definition, and our current diagnostic criteria is based on this third component of the definition. So, components 1 and 2, now we label these as pre-COPD. That is, there are symptoms, there is small airway disease, they may have emphysema, but they do not have airflow obstruction. And when airflow obstruction is present, then it becomes COPD. So pre-COPD plus obstruction is equal to COPD. So the O in COPD stands for obstruction, and obstruction is confirmed by spirometry, which is fundamental. We need to give a bronchodilator and obtain post-bronchodilator value. So post-bronchodilator value of FEV1 by FVC less than 0.7 is diagnostic. The actual change between pre and post does not matter. So we are not looking at a bronchodilator response. We are only looking at a post bronchodilator value, and it is a ratio which tells that there is obstruction. So this condition has to be satisfied before a diagnosis is made in a suspected patient of COPD. So the diagnosis depends on symptoms, exposure to risk factors, and confirmation by spirometry. So that is how Gold has defined spirometry value in COPD right from the first guideline to 2025. 25 years the criteria hasn't changed. So that is the diagnostic criteria for COPD. There is also a classification of severity of obstruction. These are called gold stages. Now, the purpose of this staging has gradually become less and less. Before 2011, the treatment was based on classifying the patient in stages, but now this has been given up. So the gold guidelines do retain staging, but what to do with the staging, that is not clearly defined now. So the purpose now is gradually going, or possibly they will just remove it from the next guidelines. Now, spirometry is very, very important in studying the whole pathogenesis and evolution of COPD. Now, this slide shows trajectories over the course, and this is what has led to the newer concept that the way FE1 develops in our life from childhood to adulthood and how it declines, that will determine how much likely a person is get to get COPD. So this is a very fundamental research. That is one of the major applications. Otherwise, spirometry has uses, but besides diagnosis, its uses are very, very limited. So this is a gold slide, and there's another one which I have further elaborated. So where we can use spirometry, one, differential diagnosis of dyspnea on exertion. Any patient who comes with dyspnea on exertion should have a spirometry. Then the diagnosis of COPD. In fact, COPD is the only disease which is diagnosed on spirometry. Otherwise, spirometry only gives a clue to the physiological patterns of abnormality. But the criteria of COPD diagnosis is based on spirometry, as I have just mentioned in the previous slides. Now, some patients of COPD do have an asthma component, and that is one of the indications for inhaled corticosteroids. In recent years, terms like asthma, COPD, overlap, or ACOS have been used, but the recent gold guidelines have discouraged the use of this term, and asthma and COPD are two separate diseases now. But if there's an asthma component, which is quite common, then there is an indication, and that can be established by spirometry. Risk prediction is a very important indication for spirometry, and there are different indices like Bold Index. Preoperative evaluation, especially in thoracic surgery, lung transplant, and other interventions in pulmonology, and follow-up of natural history. So this is where we are using spirometry now. Where spirometry has limited or no role, this is extremely important because this is a big change from our previous concepts of COPD. So classification of severity disease, we don't use spirometry any longer. Now we have got, after 2011, the ABCD classification, which is now ABE. So that does not contain spirometry. Starting pharmacotherapy in patients, that is not based on spirometry, that is based on ABE classification. Changes in treatment when the patient comes on follow-up. Again, we don't use spirometry to make changes in treatment. We may fine-tune it, but that is not a specific indication for spirometry. In exceptional cases where there is a discrepancy between patient's symptoms and examination, we may use spirometry. But by and large, treatment decisions today in spirometry are not, in COPD, are not based on spirometry. Then what about bronchodilator response? There was a time when there was a concept that COPD is a disease where there is no bronchodilator responsiveness. Now that concept has been given up. If we look at the different kinds of responses, then more than 50% of patients of COPD will have a bronchodilator response, and which is expected because bronchodilators are the drugs of choice for COPD. So these responses can be flow responses, that is FE1 improves, volume responses, which is FVC improves, or both may improve. Responses are especially very common. Why we give a bronchodilator in diagnosing COPD is to get a post bronchodilator value. So we do not actually look at the degree of improvement. So we only look at the post bronchodilator value to make a diagnosis. Bronchodilator response is not reliable to differentiate asthma from COPD. It is not a reliable indicator for inhaled corticosteroids. It is not a reliable predictor of long-term response to LABA and LAMA. So this is very important to understand that the bronchodilator response has a limited value in COPD. The gold guidelines in recent years have emphasized that the pre-bronchodilator spirometry should be used for screening. If the pre-bronchodilator spirometry is normal, that practically rules out COPD. Post-bronchodilator response is required to confirm spirometry. So the change is not important. The post-bronchodilator value is confirmatory of COPD. There are other tests like lung volumes. The lungs volumes which are important are RV, FRC, TLC, and the RV by TLC ratio. Lung volumes are technically very difficult. Very few labs in India actually get it right. And there are different techniques. There are body plethysmography techniques, there are gas dilution techniques, there are washout techniques, and they give different results. So that is what has limited the clinical value of lung volumes. Still, we have got certain important terms based on lung volumes. Increased TLC is called hyperinflation. The only cause of increased TLC in disease is emphysema, no other disease. Increased RV by TLC ratio is air trapping. This is suggestive of emphysema, but may also be seen in severe asthma. So clinical value of lung volumes is not very well established. So it is not done in majority of cases. If you have the facility and you want to understand the pathophysiology of disease better, plan rehabilitation or specifically lung volume reduction surgery, then there is a role for lung volume. But by and large, in routine cases of COPD, lung volume estimation can be done without. Diffusion capacity is important to establish the diagnosis of emphysema. Emphysema can be diagnosed only by two tests. One is diffusion capacity, the other is CT scan. It helps to differentiate difficult cases of asthma and COPD because in asthma, DLCO will always be normal. When diffusion capacity is reduced out of proportion, that is a pointer towards development of pulmonary hypertension. Diffusion capacity clinical utility is there in non-pharmacological interventions for emphysema like planning surgeries, and it is maybe of some use in follow-up of natural history. So it again has a limited use compared to spirometry. When we talk of different lung function tests, and we'll be discussing more during our panel discussions, then the issue of interpretation will always come up. The test has to be interpreted in a very specific and a planned manner. So talking of spirometry, we look at the shape of the curve to see it's acceptable and repeatable. That is very important. Shape gives the clue. In COPD, we'll get a concave upwards. I'll be showing some cases later on. Now, when we compare the patient's measured value, we make three comparisons. One, we compare with predicted values to see whether these are normal or altered. Then we compare the values with a known physiological pattern, that is it obstructive or restrictive? And then very important, a serial comparison. Does the patient have any previous tests to know whether the patient is improving or deteriorating? Then we must consider the clinical aspects, the pre-test probability. Lung function tests are not interpreted in isolation. We must have other imaging modalities and clinical data with us to establish the diagnosis and advise on further testing because there are so many other tests which can be done if indicated. We should not be ordering tests haphazardly as a package Some centers do that, and which is not a desirable practice. Only order tests which are important. Now, prediction values are very, very important. We have our own prediction values because these differ with ethnicity, gender, age, and height. So this is the general format of a prediction equation for any parameter. There is a constant, and you require information on age and height, and sometimes weight. Another component in the equation is called the standard error of estimate. So this is very important to report the abnormality, which we will discuss shortly. Why SEE is important. Now, when we pick up the prediction equation, there is a lot of choice available in software, but we should be very careful which equation we are selecting. Inappropriate equations lead to errors in interpretation. I have seen reports where GLI, Knudsen, ECSC report equations are used, and pulmonologists may not be aware what the technician is giving, but it is extremely important because there are a lot of errors when inappropriate equations are used. So what is abnormal? Outside normal values are abnormal. We should not use simple formula like values less than 80% of predicted are abnormal. This is not right because this is error prone and discouraged. We always define upper and lower limit of normals. Now, what is upper limit and lower limit of normal? This depends on the standard error of estimate. So from the predicted value which comes from the equation, we subtract a product 1.645 into standard error of estimate. This gives lower limit of normal. We add this product, this gives the upper limit of normal. In spirometry, only the lower limit is important. There is no upper limit of normal. In lung volumes and diffusion capacity, both upper and lower limits are important. Now, a word of caution, the gold definition of obstruction is strictly for COPD. It is not to be used in any other disease other than COPD. So we do not apply this rule of obstruction to diagnose cases of asthma. So it is not a general rule for diagnosing obstruction. The general rule is a value which is less than lower limit of normal. So this is the concept of lower limit of normal. So this is a predicted value. This is a graph from one of my recent publications in Lung India. So one standard of estimate gives a Z score of -1, and 1.645 Z scores is the lower limit of normal. So in reports, you might have seen the measured values expressed in terms of the Z scores. So when these scores are less than -1.645, they indicate abnormality. So these are the prediction equations for India, and these are available in most of our commercial equipments. This is a comparison why if we use other equations, things can be horribly wrong. Other equations like the American or the GRI equations, they will classify even normal patients, with those with normal lung function, as having disease to the tune of almost 25%. So therefore, we must select Indian value. That is very, very important. Now, a quick glance through a few cases. We'll be discussing more about these later on also. So this is case number 1, a 24-year-old man presenting with dyspnea and cough for 4 years with wheezing and seasonal variation. So this history is quite suggestive of asthma. Patient also had sneezing and rhinorrhea. On examination, prolonged expiration, eosinophilia raised IgE. So spirometry shows obstruction in this patient because when we look at the FMFVC ratio, it is reduced. And after giving bronchodilator, there is a substantial improvement. So history-wise, this is asthma. This is confirmed by doing a spirometry and bronchodilator response. If you look at the flow volume curve, there is a concavity. Now, this curve can well be seen in a patient with COPD also, and some patients of COPD may have bronchodilator response also. So, it is very important to consider the history also before making a diagnosis. A substantial bronchodilator response is more likely in asthma, but it is not unlikely in COPD. So, that differentiation is very, very important, that we cannot be certain about diagnosis without the history. So in this patient, it was the history and spirometry which established the diagnosis of bronchial asthma. Now, this is a 60-year-old man presenting with dyspnea on exertion, a grade 3 dyspnea with cough and phlegm, substantial smoking history, hypertensive patient because of his age being 60 plus. So this patient had a chest X-ray, which is very classical for COPD. This bowed sternum kyphosis, hyperinflated chest. So even before the patient undergoes spirometry, we are pretty certain that we are dealing with COPD. So when we look at the flow volume curve, it shows a deep concavity. Now, this kind of long tail, sometimes called rat tail, this is quite diagnostic of emphysema. If you look at the values, the FVC is 2.18, FE1 is 0.69, the ratio is 32%. So this patient has an obstructive abnormality. After bronchodilator, the FVC has improved from 2.18 to 2.82. So that is substantial improvement, but that does not make this patient a patient of asthma. So this is the volume response that I referred to in one of the earlier slides. Patients of COPD can have a volume response. So again, lung function testing is suggestive, but it has to be correlated with imaging and history before a diagnosis is reached. Now, so in this patient, the post-bronchodilator FE by FVC ratio is 31%, so which fulfills the gold criteria of diagnosis. So with history and spirometry, because patient also had exposure to risk factors like smoking, so that confirms that this patient has COPD. Now, in this patient, there are other tests which can be done to further establish the pathophysiology. We can do a diffusion capacity test, so that will show air trapping and hyperinflation, and diffusion capacity will be reduced because there is a substantial emphysema. Now, another patient with progressive dyspnea, again a heavy smoker, 73 years old. So this superficially may look like COPD, but examination has certain distinct signs like clubbing and bilateral Velcro crackles, certain signs which are never seen in COPD. So this patient had exercise desaturation, which indicates that there is a gas exchange problem. A 6-minute walk test, which is reduced. Now, this test can be similar in COPD also. So, in this patient, a greater care is required, that we don't start treating the patient as COPD. There are certain features which are different from COPD. So when other tests were done, so that cleared the diagnosis. This is an X-ray which looks so different from the second case that we have seen, and the CT scan is showing the typical findings of an interstitial lung disease. And then spirometry shows that there is no obstruction. The FE1 by FVC ratio is 82%, so which means it is in the normal range. So that is what the gold criteria on bronchodilator testing is, that if the pre-bronchodilator spirometry is normal, that rules out COPD. So this is a patient of interstitial lung disease, and so this was confirmed by total lung capacity, which showed a reduced TLC, that is restriction, and diffusion capacity was reduced. So diffusion capacity can be reduced both in ILD and COPD, but TLC is increased in COPD and TLC is reduced in ILD. So this is about the lung function tests, and so we'll go on to the panel discussion with, so I hand over back to our chair for the evening, Dr. Agam. Thank you very much.
Wow, that was fantastic talk, Chhabra sir, I must tell you. And now, if Krishna was here, he would have used this song by Alka Yagnik. वो बोलती है ना कौन सा, मुंबई से गई दिल्ली, दिल्ली से गई पटना, पटना से गई somewhere else, फिर भी मिला सजना. And we are also going to have the same thing. We've got all India presence. We've got people from Mumbai, we've got people from Chennai, we've got people from Patna, we've got experts from Delhi. So we are also going to travel from one place to the other place. And trust me, Alka Yagnik did not find us such enough, but I'm sure I'm going to find all answers to my questions. And I'm going to give all ready-made answers to all delegates who have probably given their questions to me. So if you have any further questions, use the chat box which is there on your screen. Put as many questions as you have, and I assure you, none of these experts. I've got Dr. Chabra sir, I've got Dr. Murali Mohan sir, I've got Indu there, I've got Madhukar there, I've got Dr. Varun Jethani there, I've got Supreet there. None of them would leave till the questions are answered, till all the queries are sorted. So before I take up questions from the panelists, let me ask the first question to Chabra sir. And I want to begin my journey from the heart of India, Delhi, the capital city, and incidentally, also the asthma capital of our country or the COPD capital of our country, a city where air itself seems to need bronchodilator. I think we need to pump in bronchodilators in the air with so much of pollution there in Delhi. So Chabra sir, you've been on the forefront of this lung function research. Let's start from you. How did the lung function test evolve from the simple tools? I remember when I was a student, we had that huge underwater bellows. You blow into that machine, the bellows would move. There was a cursor. We would plot this particular graph, and now we've come to this smaller machines which are there in the room. So how do you look at the entire journey? Give us your views, your 4 decades of experience with this spirometry. Chabra sir.
I'll take you a little further back into history
Ah,
and talk about a gentleman called Hutchinson. You know,
Chisholm, yes.
everybody knows who is Hutchinson.
Hmm.
Clinical method, so that is how the examination begins. Now, he devised a machine. It was the first spirometry,
Hmm.
and you'll be surprised that it was developed not for lung diseases, but it was developed for cardiac diseases. So,
Hmm.
vital capacity was the term given to the volume which was measured in that, and vital capacity
Hmm.
came out to be a very strong predictor of cardiac mortality. So, that is the genesis of spirometry, that it was not for
Oh.
lungs but for cardiac
Hmm.
mortality. So, good 100 years
Hmm.
passed before we got into the era of what we know as a flow volume loop. So, this came in late 50s. And we at Patel Chest, at that time, there were no electronic equipment. So we used to make our own spirometers. And the one that you are just mentioning, the balloon and the
Hmm.
big drum
Hmm.
over a water. So we
Hmm.
used to make those spirometers. So journey of
Oh.
development of spirometry is very interesting. Gradually, it became computerized, miniaturized, and now it is so small that you can do it on your mobile also, and possibly over telephone, you can get a patient's lung function data also. So that is how
Oh.
the science has progressed. But the
But sir,
information that we
you would
get from
make means how would you
spirometry,
make it? How would you
pardon?
make spirometer? Matlab, you said those were the days when you used to make your own spirometer. How do you
Oh,
make
yes.
spirometer?
There used to be a big bell which was inverted over water.
Uh-huh.
So it was a very simple
Uh-huh.
physical phenomenon that it's a closed chamber. So when you blow into a closed chamber, the bell will rise,
Hmm.
and the increase in the bell volume will be directly proportional to how much you blow the air into it, because it collects the air that you have blown into it. So that
Wow.
was vital capacity. And then at the mouth, we can measure at what rate the air is going out of the lungs. So we
Hmm.
could calculate FEV1.
Wow.
So that was the humble beginning of spirometry as we know today. But interestingly, the definition of vital capacity and definition of FEV1, they remain the same as it was at that time.
Wow. Interesting. Thank you, sir. Now let's move from the most polluted city to the most congested city, and that's Bangalore. So Dr. Murali was stuck in the traffic, and I can see happily he's settled in his cabin where we are talking about city where traffic itself is a pulmonary stress. Despite of all those honking and haze, it is also the city where air pollution is the most prevalent. city where innovation starts. IT city hai apna Bangalore. So let's talk about, let's learn from Bangalore. Let's learn from Dr. Murali Mohan. Okay, sir, what do you feel? What were the major turning points on this, our understanding of spirometry on COPD? I'm sure people were diagnosing COPD just on clinical basis, and I'm sure a lot of us still prefer diagnosing COPD on clinical basis. And what actually happened, which made spirometry indispensable for COPD diagnosis? Over to Dr. Murli Mohan.
Yeah, so I think Professor Chhabra already elegantly covered it in his talk that when you have a disease called chronic obstructive airways disease, you've got to demonstrate obstruction. And the obstruction is to airflow. So unless you can demonstrate that there is airflow obstruction, you can measure this obstruction, then really to make a diagnosis of COPD rests purely on how you view the original diagnosis or the definition of chronic bronchitis, cough with sputum production lasting at least most of the days in a month, 3 months in a year for 2 consecutive years. That is purely a history-based definition of chronic bronchitis. And the emphysema was actually purely a pathological diagnosis. So you can't do those. So spirometry started off, as Professor Chhabra said, almost 100 years after the spirometer was invented. And interestingly, if you look back at, the original use to determine, cardiac status, it's actually a very good determination because the Framingham study showed us that FVC was a better determinant of outcomes, cardiac outcomes, all-cause mortality, cardiac mortality than, any cardiac measure itself. So we've learned all these things over the last 30 to 40 years, 60 to 70 years after the use of the spirometer was recognized in even textbooks. So the first description of COPD being defined by spirometry came in one of the ancestral books of Murray and Nadal. So we use Murray Nadal now. The earlier versions, which Professor Chhabra and I will remember, I think it was called Hinshaw Murray. And before that, it was Hinshaw Garland. So one of the early editions of Hinshaw Garland was the first definition of spirometry as being a basis for COPD diagnosis. Before that, it was all purely clinical. So recognizing that measurement is essential, we have the definitions that Professor Chhabra has already told us. So I would say that our first recognition is that there is airflow obstruction, which we knew clinically earlier. Lennox himself, by a combination of auscultation, examining a hyperinflated chest, during autopsies was able to show the hyperinflated lungs, was able to recognize what the problem was. But you can't prove it unless you actually have a measurable entity. And that's where the spirometer came in. It gave us a measurable entity. It also gave us some early inclinations of, when you have reversible disease, it is asthma. If it is poorly reversible, it is COPD. We may dispute that now. We don't think that those definitions hold good, but at least it gave us an initial inkling of there are two separate diseases. Unlike the earlier Dutch hypothesis that thought it was all one disease, we now recognize that these are separate diseases. They may have some overlap, and even that has come in with the understanding of spirometry and the concept of reversibility. So I think those are the two main things that we have recognized. And as time goes on, and we've recognized that there is small airways disease, and small airways disease is an integral component of COPD and enables us to pick up COPD fairly early and introduce changes in lifestyle, exposures, and so on by picking up these early pre-COPD and PRISM components. All that has come with the use of spirometry. So that's where I think spirometry historically has taken us through the earlier recognition, definitions, which have been improved over time. And now we are trying to go back into these, trajectories of airflow obstruction that take us back earlier and enable us to intervene earlier.
And I think the ease of spirometer, I think it has become very easy also to perform spirometry. That may also have added to more use of spirometry in diagnosing various diseases. Wouldn't you agree?
Yes, I mean, it's become an integral part of preoperative evaluation, for example. especially when you're doing thoracic surgery, if you're doing lobectomies and pneumonectomies, you will not have the courage to proceed without doing some kind of evaluation at the very least. It's become easier to do because of the new kinds of pneumotachographs. Professor Chhabra spoke about the water seal spirometer. I have used initially bellows spirometers, which basically the bellows expands. That was a very easy way to do it. And the computerized things, the pneumotachograph and all has come later. And of course, we can have a disputative discussion about impulse oscillometry later, but that has also enabled us to do things where patients are unable to perform spirometry. So we have alternatives. And as Professor Chhabra said, the CT is indispensable in the recognition of emphysema at its different stages. And if you combine lung function testing with history, with CT, then you can actually get a reasonably good understanding for your patient management of COPD.
Great. तो भाई दिल्ली से हम गए बेंगलोर, बेंगलोर से आए मुंबई. I welcome you all to my city, Mumbai, and I welcome Indu for this. So Mumbai, as I always say, is the city of paradox, where the richest of the rich share the same air with the largest slum, that is Dharavi, shares. And yet, the spirit of Mumbai keeps everybody moving. Even when the air quality index says don't, but we don't stop, we keep on moving. Indu, what are your limitations on this spirometry issues in early days, or probably, last decade or so, if we may say, a lot of change in the way we do the ease of spirometry. There are problems in interpreting spirometry, FEV1, FVC, the transition from post bronchodilator 0.7 has really reshaped the diagnosis of COPD. So your thoughts on it, Indu?
Thank you so much, Agam sir, and thank you CCI for making me a part of this. So when we are looking back to history and early years of the spirometry has been really challenging because the instrument lacked the calibration consistency, and the spirometry reference range were actually race specific. So it led to variability in the FEV1 across the population. Then in 2022, GLI reference equations came, which were race neutral, and it was endorsed by ATS, ERS, and GOLD guidelines, which led to improved, accuracy worldwide. Then historically, we thought that only post-bronchodilator values were reproducible, but now GOLD realizes that even pre-bronchodilator values are reversible. So it eliminated a lot of confusion between the volume responders and the flow responders, which we earlier physiologically interpreted to be asthma and COPD. That confusion is eliminated. So the diagnostic sequence right now is we first measure the pre-bronchodilator FEV1 by FVC ratio. So if it is more than 0.7 or equal to 0.7, then it is not a COPD. And we only do a post-bronchodilator if there is a volume response which is suspected, or if the symptoms are very, very high. Okay, and it is not a COPD. So then second part is if the FEV1 FVC pre-bronchodilator is less than 0.7, then we confirm COPD by doing a post-bronchodilator value. If the post-bronchodilator ratio remains below 0.7, that it means then it is a fixed airway obstruction and COPD is confirmed. If the ratio improves after giving the post-bronchodilator, that means it's a flow response. And then you have to reassess the patient again at a later interval by doing a spirometry. Now, GOLD also recognizes that this fixed cutoff ratio actually overdiagnoses COPD in the elderly and underdiagnoses in the young people. But that risk is very, very limited. GOLD also emphasizes using the lower limit of the normal to eliminate this risk in this population. Okay, so this whole transition has helped us to diagnose COPD very well, and it has made spirometry a cornerstone of our clinical practice. It has helped us here.
Wow, wow. So that's from Indu, and from Mumbai, every time had to go to Patna. So I take you from this Darya Kinara of Mumbai to the spiritual soil of Patna, jहाँ history, heritage, and humanity blends beautifully. Patna reminds us that COPD is not just the urban problem. It's much alive, even in the heartland or even in the heritage place also. So Madhukar bhai, before spirometry became routine, we were looking at COPD and chronic bronchitis, and we differentiated them clinically. To whatever lessons we learned from there, do you still also do that phenotyping of chronic bronchitis or emphysema, or you label everybody as just COPD? Madhukar.
Thank you so much, Dr. Agam, sir, and welcome you to Patna. I thank CCI also
Excited.
to
Yes.
have me here. So thank you so much, everyone. Sir, your question, like in pre-spirometry era, how we used to diagnose COPD. I remember when I was having my post-graduation, from the very first day, I got my duty in the spirometry room. So I don't
Hmm.
have much experience to deal with COPD without spirometry. But at the same time, when we were in the clinical round, where the patients came and got admitted without having a spirometry done before, we always used to have this discussion where the patient has emphysema or the patient has chronic bronchitis. So
Hmm.
during those days, we were actually focusing in these two entity to diagnose the patient with COPD. So a chronic bronchitis patient, as Dr. Murali sir was telling us, that uh, chronic cough with sputum lasting for at least 3 months in a year for two consecutive years. But we always forget this caveat that there should be no alternative explanation for these
Hmm.
symptoms. So that caveat has to be borne always in the mind, and we missed it during our clinical round also. These patients with chronic bronchitis were typically called blue blotters because they were more hypoxic, and they developed cyanosis and they developed core pulmonary earlier in the course, unlikely emphysema, as the patients of emphysema were more dyspneic than having chronic cough, and they were called pink puffers. They do not develop hypoxia early in the course, and they do not develop core pulmonary early in the course, unlike chronic bronchitis. And these patients on clinical examination will used to have barrel sepate chest. So this is how we used to, diagnose emphysema and chronic bronchitis in pre-spirometric area, pre-spirometric era. So coming to the next part of your question, which is very pertinent and which is very exciting. Let's see whether we are retaining those emphysema predominant phenotype or chronic bronchitis phenotype is still in our practice. So let's see the patient with chronic bronchitis phenotype. It was an interesting study in the chronic bronchitis phenotype that told
Hmm.
us that the patients of COPD, at least 30% of them can have large airway involvement also. And it came from the study from the patients with chronic bronchitis. And I'm telling you that the mucus matrix, that the phenotype that we are not discussing about, that COPD phenotype of chronic mucus hypersecretion, also
Hmm.
came from the study from the chronic bronchitis. And also we came to know that the air trapping and hyperinflation doesn't do not occur only in the patients of emphysema. It also occur in the patient of chronic bronchitis. For example, a patient of chronic bronchitis or COPD who expresses MUC5B, they have extensive mucus plug in the small airway, causing air trapping and hyperinflation. So this was an interesting study. And finally, therapeutically also, it is very, very important. Now, a patient of chronic bronchitis who produces excessive mucus, those are the patients who tend to have large airway disease, and they have predominantly neutrophilic inflammation. So when these patients exacerbate despite triple therapy or despite double bronchodilator, now these are the patients who have predominantly neutrophilic inflammation and would respond to either dofolium or macrolide. But those patients who have mucus plug on the CT, have air trapping and hyperinflation, they tend to have TS2 eosinophilic inflammation. And if these patients do exacerbate further and further, despite triple therapy, now these are the patients in whom we prescribe dupilumab and now mapelizumab also. So therapeutically, this distinction is important, and we need to identify that these patients are having chronic bronchitis. Similarly, with emphysema, the patients on maximal medical therapy is still dyspneic. We go on to see whether the emphysema is and whether the collateral ventilation is there or not to decide on the lung volume reduction, whether it's bronchoscopic or surgical. So it is very important that it is retained till now that we need to phenotype these patients accordingly. Thank you so much.
Madhukar bhai, when you were talking about it, I have always felt this term mucus hypersecretion a misleading term. Why do you call it a mucus hypersecretion? Normal lungs are not likely to produce any mucus, right? Or if you have to say hypersecretion, then you have to define what is normal secretion. So it's like, earlier days we used to talk about hyperacidity and we realized that that's a wrong term. We don't use hyperacidity anymore. Don't you think it is a time to think about mucus secretion than mucus hypersecretion? What do you feel?
Absolutely right, sir. And the society is working on it. We are moving from a term chronic mucus hypersecretion phenotype to a term where mucus predominant phenotype. So this is what we are shifting on, and later on we'll be seeing more and more into it. You are absolutely
Great. So friends from Patna, it's a time to go to Dehradun. So let's travel to north again, nested in the foothills of Himalaya, my favorite place, and where you feel that lung will be absolutely healthy because air is going to be absolutely pure. But trust me, reality speaks otherwise. Varun bhai, we are going to ask you, what are the different lung function tests that are available for day-to-day clinical use other than spirometry? And do you think this kind of tests really help you in taking decisions in your day-to-day COPD management? Over to you, Varun bhai.
Good evening, sir. Thank you for this question and thank you, CCI. Yes, sir, it is so true that we are exposed to so much of pollens and not of actually much of purified air. So, talking regarding your question, sir, now after the spirometry, there have been various tests. Like first would be the body plethysmography, where we can measure the total lung capacity, the residual volume, and the functional residual capacity, which detects the air trapping. And hyperinflation increases the residual volume and the total lung capacity. Second would be a preferred one, the DLCO, which is useful in diagnosing the emphysema, where there is a loss of alveolar space, and it is the DLCO value are reduced in emphysema. Third, which is now more important and more preferred by us, is IUS, impulse oscillometry, because it is more easier to perform and it is little effort independent and it detects the early small airway disease. And routine and important are like ABG, arterial blood gas analysis for diagnosing of hypoxemia, hypercarbia, and the patient require the oxygen therapy or not. The pulse oximeter to be told to the patient to be kept at home, and 6-minute walk test to be done by the patient when it comes, as it is a part of a board index, and we can assess the disease severity and the quality of life with this. And what can be done at the home is peak expiratory flow meter, and if required we can go for an image based lung function to see how much is the involvement and the emphysema, or we are planning for any surgery that would be required.
Great. Absolutely perfect. So then let's complete our national tour first. Now it's the time probably to move to Chennai, the city of warmth, the city of wisdom, and the city of fantastic idlis also. Chennai has taught me about discipline, about clinical clarity, are the real strength in managing chronic disease. So, Supreet, I want your views. How practical you think is to put spirometry into your decision of treating a COPD patient? Would there be any differences if spirometry results are otherwise in managing a COPD patient? And how does, apart from diagnosing COPD, spirometry helps you in deciding treatment plan? We just heard Dr. Chhabra saying that spirometry may not have much role in decision making when it comes to treatment. Of course, diagnosis apart. What do you see in Chennai?
Yeah. So good evening, sir, and all the esteemed panelists, and also CCI for giving this opportunity. So spirometry, apart from diagnosis in COPD, it has got a very important role in assessing the severity of airflow obstruction. And apart from that, you can identify the phenotypes, those who are rapid decliners. And even we know that FEV1, those who are low FEV1 is also a risk factor for risk exacerbation, so exacerbators. It also helps in some follow-up assessment like pharmacological management in those when there's a discrepancy between COPD patients and symptoms. And also, planning the non-pharmacological interventions like lung surgeries or lung volume reduction surgeries. And we know that we have to take, if spirometry does not, sometimes may not be accurate or we do not get the values, but we have to correlate clinically radiological as well as a physiological assessment. So just a physiological assessment which has to be taken along with the symptomology and taken into consideration for the diagnosis, not only for diagnosis, for severity and in prognosticating the patient and planning the therapeutic planning also.
Great. Thanks, Supreet bhai. Chhabra sir, we have a question for you in the chat. Dr. Tridip Chatterjee sir. Tridip Chatterjee sir, thank you very much for the first questions. And I knew that first question would come from you only. Thank you for always being there. Thank you for always asking such interesting, intelligent questions. And Chhabra sir, the question we expect answer from you. The MEF 2575 versus your FEV6 by FEV1 as the small airway obstruction criteria. How do you?
There was a break in your audio. Can you repeat the question again?
So it can be seen on the chat. It says the small airway obstruction. How do you diagnose small airway obstruction on spirometry? Your views on MEF 2575 versus FEV6 by FEV1.
Well, once upon a time, F2575, also called MMEF, was put forward as a test of small airways function. The word I'm using is once upon a time. So that's history. It used to be. The reason why it never actually developed into such a clinical test was that there's just too much of variability and it is volume dependent. So after bronchodilator, if the FVC increases, the F2075 will actually decrease paradoxically. And there's just too much of trial to trial variation. So practically, it is a test which is not used in interpretation of spirometry. Now, interpretation of spirometry is based only on two parameters, FEV1 and FVC. Although your spirometry report may have 10 or 20 parameters, but most of them will give information on previous value. True. So F20 of 75 is not to be relied upon. If you are an expert in spirometry and you have seen hundreds of flow volume curves, then from the tail of the flow volume loop, you can get some estimate of a small airways function, but that's not a valid test. So spirometry is affected by small airways disease, but it is not a test for small airways function. So for small airways function, over time, different tests have been evolved. If these tests are abnormal, and in COPD, we expect every patient to have a small airway disease because that's the definition of COPD. So that is universal. If you do any test of small airways function, it will say IOS, it will always be abnormal in COPD. So the diagnostic criteria is based on spirometry going beyond strictly small airways obstruction and showing that. So pure small airways obstruction suggested by the tail of flow volume loop, or if the F20 or 75 is greatly reduced, that is early COPD, not mild COPD, early, which means before clinical COPD develops. So that's now clubbed into a pre-COPD. The other question about FEV6, like I said in the beginning, PFTs have come and gone. So FEC is also in that category only, that never got established. So it's practically something where you will read a few papers which extol its values, but there are other papers which will run down that it's a test of no use. So in practical utility, if we talk about, FV6 is not a term to be used, not a test to be used.
So if there is a normal spirometry otherwise, and is there any way of looking at small airway disease or small airway obstruction on spirometry? Your FEV1 is normal, your FEC is normal, your FEV1 by FEC ratio is normal. How do you suspect small airway disease in a normal looking spirometry?
Well, in spirometry, like I said, only the terminal tail, if that is showing in concavity, then that is suggestive. And the problem is that that is also universal when we age. So any person who is 50 plus will have that small tail because there is an airway collapsibility also developing as we age. So strictly spirometry is not devised to look at small airways. Small airways disease of significance will affect spirometry, but the reverse is not true. The spirometry is not a test for small airways.
Correct.
Closing volume was a test. It came and went. You can get some idea by RV by TLC ratio, but it again has a lot of variability. iOS will always be positive in COPD patients. So strictly, we don't have a very good test for small
Got
airways.
your point. And one more question I had for you was, how relevant is this spread of infection in spirometry? How important it is to maintain, apart from using the filtered or the disposable mouthpieces, are there any other steps that...
Like I've been doing spirometry for about 45 years. So at that, in those times, there were no filters. Filters we have been using in last 20 years or so. For
Correct.
tuberculosis, we had a separate spirometer. So that was always kept reserved for tuberculosis patients. But in our experience and in world literature, transmission of infection through spirometers has been extremely uncommon. And I'm talking about the volume spirometers, where you actually blow air into that. With pneumotac spirometers, the volume is exhaled out into the air, so there is no question of any kind of transmission. So we can practically say there is no risk. We only use filters for hygiene purposes, and the patients, they would prefer that using a clean machine, so that is the purpose.
Fantastic take-home message for friends who are attending this program. Please don't worry about the spread of infections, etc. Of course, the disposable mouthpiece is in need of time. It's more hygienic. It's more acceptable by society. But don't worry. Don't think that you will get, the patients will have cross-infection because of...
In COVID times, we were very hypersensitive, but then we were hypersensitive about everything in COVID times,
True. Yes. Dr. Mohan sir, we did speak about reversibility on spirometry. How relevant is this reversibility component in COPD management? Or would you really look at reversibility on spirometry while you're managing the COPD patient, and would it really change your decision?
Not really. So, we have used reversibility in the past to differentiate between asthma, COPD, and also to talk about asthma, COPD overlap. Probably is not very relevant now. And if you look at the gold guidelines, they're very, where it really comes in useful is if you want to use inhaled steroids in a person with COPD. And the guidelines are clear. You use it only when you have a good, other features to support asthma, COPD overlap, a previous history, an association with allergic rhinitis or other atopic features. If you have a eosinophil count which is greater than 300, which again, a number that can be disputed in India to some extent. And of course, if you're a frequent exacerbator. So none of them include the concept of reversibility. Okay, so reversibility as a measure of how you're going to manage your COPD is probably not relevant. Again, Professor Chhabra made this point that you make the diagnosis of COPD only by giving the person a bronchodilator, looking at the post-bronchodilator FEV1 by FVC ratio, and then saying, yes, there is obstruction. So in that sense, if the person has shown some evidence of airflow obstruction immediately and that gets corrected after you give a bronchodilator, you will probably not even make a diagnosis of COPD at that stage. Okay, so the relevance of COPD, reversibility in COPD probably does not exist very much. However, you'll find it as a useful add-on. You have a history, you're still torn between a diagnosis of COPD and asthma. You have all clinical features. Professor Chhabra showed us one case where it looks like the other features also support an atopic response. Then maybe I'll say, look, this is an additional small evidence, and I'm going to treat this patient as asthma or asthma COPD overlap rather than purely as COPD. So that's where you have to integrate, and this is true of all spirometry. Spirometry is not a standalone, point to make a diagnosis. It is based on your pre-test probability, your assessment of the history, examination, and then you say, yes, now I am convinced that this is COPD based on this spirometric parameter, or I think I have to think of something else because this does not fit the definition completely, and this does not fit the clinical picture completely.
So if I have to ask you of doing a PFT for a COPD patients, would you still call him without bronchodilators, give him the inhaler, and then again do the spirometry, or you would tell them continue your treatment, come and I will do your PFT? How does it go in your OPD?
So I find it's useful to do spirometry periodically to assess how they are doing, what is happening to their lung functions. But I would go much more by, the usual questions we ask about how is your exercise tolerance, doing a clinical examination, have they had exacerbations in the last few months? But yes, I think doing spirometry periodically is useful. You don't need to do it at every visit. I would probably do it once in 6 months to a year. And I call my patients back once in 3 to 6 months anyway. Unless there is a worsening of symptoms recently, if they've had some change in symptoms, then yes, I would like to find out what caused it and how to document it. I think Professor Chhabra wanted to add something.
If we look at the evolution of gold, then a landmark is 2011. Before 2011, we had this gold staging, and treatment was based on gold staging.
True.
FE1 part of that. 2011, the ABCD classification came in. And in ABCD, if you look at the X and the Y, the FE1 is missing there.
Not mentioned. True.
That's because experience taught us that it doesn't really help in fine-tuning the treatment, except in exceptional cases where a clinical judgment is important. So pulmonologist is expected to use that. But by and large, for routine cases, the ABCD classification works without spirometry. Even adjustment works without spirometry. So that is a milestone, I would say, 2011, when the ABCD classification came.
Madhukar?
Yeah. Sir, I would like to make it clear why gold is retaining this FEV1 in the whole management plan. I totally agree that FEV1 does not help us to initiate the therapy in the patient of COPD. But FEV1 is really, really important in the entire algorithm of the management. And this is why gold is not going to leave FEV1. There are three things that gold meeting clearly explains us. Though FEV1 does not help us to initiate the therapy, it does help us in the advanced therapy of COPD. For example, you would never subject a patient for lung volume reduction if FEV1 is less than 20%. Second, FEV1 is important because if you are treating a patient and if you do not have a baseline FEV1 value, you are not going to recognize the patient who is rapid decliner. And now rapid decliner is a distinct COPD phenotype. So it is important to recognize those rapid decliner also. And third, FEV1 is still the most important surrogate marker for mortality in the patients of COPD.
See, all these were referred in that slide. No? There's a slide which mentioned that this is where we use spirometry.
So this is why, sir, we need to have FEV1, which is the management algorithm of the patient with COPD.
That was a different aspect of spirometry, which I had mentioned. What we are talking is in the routine management pharmacotherapy, there the lung function is not used to start and change the treatment.
Sir, what would you do if a patient who is on double bronchodilator therapy, group B, goes on to lose FEV1, for example, 100 ml in last 1 year?
But see, your treatment, you don't have many options.
You see, if you look at the gold guideline, there are two options available.
We don't have many options.
Whether we are dealing with an dyspnea or we are dealing with an exacerbation. Right? So we'll have to identify the possible phenotype. So if there's an indication of inhaled corticosteroids, then inhaled corticosteroids are added. So there is a distinct...
This is why I say that FEV1 is going to stay in the entire management.
No, I think we should send the correct...
FEV1 is going to stay, there is no doubt.
Disagree.
But
Yeah, go on, Dr. Agam. You want to say?
No.
Yeah, I think it's just important to not discount FEV1 completely. That's important.
Yes.
The point that both Dr. Chhabra and I are making is that it doesn't influence your immediate management. Okay, so it's useful to have a measure of where down the pathway this person is, but it doesn't really change your immediate management.
Yes,
Yeah.
sure.
And anyway,
So,
you don't have many therapeutic options. Your
Yes.
starting of steroid or starting of third drug may not be on monitoring of FEV1. It would be more on clinical symptoms and more on number of exacerbation patient
There's
has.
one important point in asthma and COPD, the goals of treatment. In asthma, our goal of treatment is to get a normal or a near normal lung function. In COPD, that goal is not there. So, distinct difference between the goals of the two diseases.
Great. We've got 1821 logins is what I see on my chat. So there are, thank you CCI, thank you all members, thank you all family members for joining in today. The next question is for Indu. Indu, we are talking about this diffusion capacity. Do you think diffusion capacity helps you in managing COPD patients? And if so, would you monitor DLCO?
So basically, DLCO gives us an extra edge over spirometry. Spirometry tells us about the airflow obstruction, while DLCO tells us about the gas transfer efficiency, how well the oxygen is getting, crosses the alveolar capillary membrane. Now, a normal DLCO is not consistent with emphysema phenotype of the COPD. In the emphysema phenotype of the COPD, we will have a fall in the DLCO because of the alveolar wall destruction and the loss of the surface area. Okay, so we will have a low DLCO. The alveolar volume could be high because of the hyperinflation. TLC could be high. VA TLC could be preserved or it could be high, and we will have a low KCO. Now in asthma, DLCO could be is high. A DLCO and a KCO is high. In chronic bronchitis phenotype, a DLCO is normal. Okay. Now, in the combined COPD and asthma phenotype, when the patient is a smoker and it is an advanced asthma, then we should think about, and if there is a low DLCO, then we should think about the emphysema dominant ACOP, asthma COPD overlap. Now, if you're thinking about combined pulmonary fibrosis with the emphysema, then here also DLCO will be low. But here the alveolar volume will be low, the TLC will be low, and the VA by TLC will be low, right? Because of the fibrosis. And the KCO is also low. And if you have, when we are giving the maximum bronchodilation to the patient of the COPD, and still you have a moderate airflow limitation on the spirometry with a very low DLCO, then I would consider to do a CPAT in that patient. And if the CPAT is showing a circulatory limitation to exercise, then I would think about the pulmonary vascular phenotype of the COPD. If there is a ventilatory limitation to exercise, then I would think about the group 3 pH of the COPD. So this is how DLCO helps us in in understanding the different phenotypes of the COPD, and that is how we manage, Now, DLCO also helps us in prognosis of the patient. So a low DLCO is actually associated with increased symptoms. It is associated with increased worse quality of the life. It is associated with the survival. It is associated with increased risk of death and increased hospitalization rates. It also guides us for the perioperative risk assessment. So a low DLCO can actually defer a lung resection in the lung cancer patients. A normal DLCO or a predicted post-operative DLCO of more than 60 and a predicted post-operative FEV1 of more than 60 tells us that it is a low-risk patient. So DLCO helps us in the diagnosis also. It helps us as a prognostic marker also. A lot of value for DLCO. Yeah.
So how often do you do DLC in your COPD patients?
So if required, if the patient is still symptomatic, dyspneic despite the airflow obstruction, then you should always do a DLCO.
How will it help you change your treatment? Your patient is on dual bronchodilator with steroid. Your patient is not doing well, is breathless. You will do DLCO. What interpretation, what change in treatment?
So these are the treatable traits of COPD. Like if you have an emphysema predominant, then you have a different management. If you have a pulmonary vascular phenotype of the COPD, then you have a different management. You will do a right heart catheterization, then you will start the anti-PH treatment in those patients. If you have a group 3 PH, then you don't have much of PH treatment in group 3. Nowadays, for severe PH, some people under the trial, sildenafil is still there. So when we differentiate different phenotypes, we can actually manage the patient differently.
Okay, get your point. Madhukar, what about this hyperinflation air trapping evaluation? Do you do this air trapping evaluation in your clinical practice? And if so, how? And does it really help you in changing your treatment?
Yeah.
There are certain inhalers which are supposed to have better effect in smaller airways. And how clinically relevant is that?
Sir, absolutely. It's very, very clinically relevant. And I do body plethysmography in most of my patients, and especially those patients of COPD who are very symptomatic despite maximal therapy. And those are the patients where I will do both DLCO and body plethysmography. So why I'm telling you, because body plethysmography is a unique test because it's a physiological test which the patient performs with a tidal breath, unlikely the forced maneuver which a spirometry is. Moreover, the body plethysmography gives us three very important information. It gives information about all the volumes more than the volumes in volume data given by the spirometry. Second, it gives us the total airway resistance, which is not given by the spirometry. Third, it gives us a specific airway resistance, which is work of breathing, which is not been given by the spirometry. Why the spirometry became the center component for the diagnosis in COPD, I believe, because body plethysmography is an expensive equipment. It needs a good technical training for the technician, and it's not very, compared to the spirometry, you need a lot of training and a lot of support from the patient to perform this test. Saying this, uh, I would tell you that how the body plethysmography is going to help us. It is going to help us in the diagnosis. It is going to help us in the prognosis. It is also going to help us in the treatment plan. For example, if a patient whose FeV1 by FVC is low, and then FVC is also low, there could be two possibilities. The patient can have combined restrictive and obstructive defect, or the patient can have single obstructive defect, so obstructive defect. And if you do not perform the body plethysmography, if you do not know the TLC, you will never be able to pick it up. So if the TLC is normal, you know that the patient does not have the mixed defect. If the TLC is low, then you go on to perform the HRCT to see whether what restrictive defect the patient has. Second, prognostically, there are two prospective longitudinal studies which says that in patient of COPD, if FeV1 is less than 50%, then RV by TLC, which is a marker of hyperinflation, is a better predictor of survival than FeV1. And it has been mentioned in the GOLD guideline also. And the third, treatment plan. Treatment plan. For example, if your patient is dyspneic on maximal medical therapy, and then you find in body plethysmography that the specific airway resistance is high, total airway resistance is not that high, and RB by TLC is high. It means the patient is dyspneic because of the hyperinflation alone. It's not the airway resistance which is involved. And these are the patients in whom, before subjecting them to any kind of intervention, I'd use more and more pulmonary rehabilitation, focusing also on the muscle strength test to see the SNP or maximal inspiratory pressure, whether they can be helped to improve the inspiratory muscle strength rather than subjecting them directly to the interventional therapy.
Interesting. Very nice. So, Madhukar, suppose if you've done a basic spirometry, you've diagnosed somebody having COPD, you put them on treatment, is dyspneic, you've given him triple drug, maximum possible treatment that you've done. Patient is still symptomatic. Would you now do body plethysmography, DLCO workup, or would you now do CT scan chest to look at associated abnormalities that you missed?
Both, sir.
Your next choice of investigation before you do body plethysmography.
If your patient is symptomatic despite maximal therapy, we need to have both a structural mapping as well as the functional mapping. So we'll have both HRCT and DLCO exercise test with body plethysmography.
Okay, great. Varuna, let me ask you this question.
Agam, may I just add to the question where a person is not responding? We have to look at other causes of dyspnea in this patient. It's not always COPD which is the cause of dyspnea. One of the major cause is a diaphragmatic dysfunction and then the cardiac function. More than a quarter of these patients would have a diastolic heart dysfunction and many would have a coronary artery disease also. So evaluation of chronic dyspnea is not complete in COPD without evaluation of the heart. That is very important in these patients.
Great, great. Varuna, may I ask you next question? We had a discussion about frequency of doing spirometry. In your clinical practice, how often do you ask for spirometry? I mean, I have a habit of asking for once in a year spirometry, and that to just basic spirometry in most of these stable COPD patients. What do you do in your practice?
Yes, sir. As sir also said, K Chhabra sir also discussed this, and as per the gold guideline also, we prefer the spirometry that is to be done repeated after every 1 year to 2 years, only to monitor the progression of airflow limitation. We prefer it early only if there are increasing symptoms, only if there is a need of treatment change, or we have done treatment change to see that, or we are planning for any surgery or advanced therapy, only then we repeat it early. Otherwise, it should be done in 1 to 2 years of play, and there would be no change as such to do early spirometry.
Okay. And suppose if you have a severe COPD patient who has got, a COPD patient who got severe obstruction, he's stable. Would you still do a repeat spirometry at the end of 1 year?
No,
severe is severe. It's not going to show any change.
No, sir. There's nothing more of we will get a practical
Would you do
value.
it, or you think it not really required?
No, not required, sir. Unnecessary discomfort and the cost increasing.
True. Great. And anyway, you don't have much therapeutic options there. So rather than doing a patient is symptomatic, as Chhabra sir said, there may be more sense in doing tests for diaphragmatic dysfunctions and associated pulmonary hypertension and maybe respiratory failure assessment rather than COPD evaluation.
In fact, in
Dr. Chhabra, Dr. Murali, do you have a different views? Yes.
On what?
See, on Dr. Mohan first, your
different views on asking for PFT in a patient who's already having severe obstruction.
Should I answer, Dr. Mohan?
Yeah, please go ahead, sir.
Okay. See, about Dr. Varuna has clearly said that it will add very little value in a patient who is stable. 50, 100 ml here and there doesn't really make a difference to the management plan.
True.
It can sometimes, be helpful in patient education that you are doing well, maintaining function. So your compliance can be improved, or at least the patient is encouraged to continue the treatment. Secondly, pulmonary rehabilitation will have to come in, although it will not improve lung function. But when lung function is bad, then the patient is again motivated to go beyond pharmacotherapy, because there is a limit to what pharmacotherapy can achieve in COPD. So from that point of view, motivating the patient as a positive reinforcement spirometry is good. But clinical management will not change unless a patient is heading towards a possible surgical intervention, where again a spirometry would be required. Like, now we have got valves available, we have got lung volume reduction surgery. So at that stage, again, spirometric assessment will come in.
Can I just add one more sentence to that, which is that when you suspect a second problem, for example, this CPFE kind of thing, that's where you will, want some additional support for your diagnosis apart from the CT scan. And that's where more frequent assessments may need to be done, not from the COPD point of view as much as the fibrotic lung disease point of view. So that's the other place where we tend to do it a little more often.
As Dr. Chhabra sir said, I think we should look at the other treatable traits of COPD. Besides doing a spirometry, I think why it is low. Also, it could be associated with bronchiectasis, some chronic infection. So the management point changes. We have seen there is a lot of anxiety and depression among these patients. So psychological counseling can help in those patients. There is muscle deconditioning, which is there, which is very, very common. So nutrition and diet could be advised there, So I think our treatment decisions would definitely get influenced. A lot of these patients have heart failure with preserved EF. So, doing a anti-pro-BNP, it is a heterogeneous lung condition. There's a lot of systemic inflammation happens. So doing a CRP probably will also help. I think it's a lot of treatable trait which we can actually explore and sit with the patient.
No, we are not discussing about what all tests. We are talking about, do we do spirometry for patients who are COPD having severe obstruction? So I think I would probably.
I think it helps. I think it helps when
doing frequent spirometries in COPD patients who got severe obstruction. If you're not planning any further treatment,
there are so many patients who are not ready to quit smoking. I think if you do a spirometry, you can repeatedly tell the patient that look at your lung functions, which are so low. This is one additional way of probably telling the patient that you need to really quit smoking. They are very, very adamant.
If you're not successful in motivating him till these lung functions have gone to that stage, I think further doing spirometry is really going to add any value. I have my doubts. But anyway, let's move on to the most
the new baby on the horizon. That is Agam, I would dispute that. At any stage, quitting smoking helps.
Okay. Yeah, and they are already
from the lung point of view, it helps from the heart point of view, it reduces the cancer risk. I mean, you don't want to give up on the patient at that point. It improves their muscle power. So I would still, I'm not saying you use spirometry for that. I'm just saying that making every effort to help the patient quit smoking at any stage is important.
Get your point. Dr. Chatterjee has a point. Routine DLCO is not done in COPD patients. Maybe if pulmonary artery pressure is high and routine testing, it may not. Yes, perfect. Dr. Chatterjee also would agree to that particular point.
May I?
Yes, sir.
See, a question about routine DLCO. Now, this will also bring in a question of what is the complete initial assessment of the patient. If the patient is coming to me and I'm categorizing him as E, and spirometry is showing a severe obstruction, then in most patients, I will also obtain a CT scan and also do a DLCO to get a complete structural and functional information about the patient so that a comprehensive management plan can be developed for this patient.
Design. Correct.
So it is clinical judgment because like we talked about bronchiectasis or associated conditions, cardiac assessment. So all this will come in as a package in patients who present initially as severe COPD. For milder patients, there is scope of just treating as per the gold guidelines, but more advanced patients, I think comprehensive assessment is required because we need a complete treatment plan. Possibly who is going to need surgical intervention later on, who will going to benefit from pulmonary rehabilitation more. So a CT at diffusion capacity, therefore, is very commonly done in patients who come with group E kind of presentation.
Absolutely. Fantastic.
So I'll just like to add over here. I mean, first hello to Dr. Trideep Chatterjee. He's been always there. So I want to tell sir that, a DLCO is a must when the patient is still dyspneic despite the maximum bronchodilation. If the airflow obstruction is moderate, let's say the PV1 is around, you get my point, right, sir?
Perfect. Supreet bhai, there is a new baby on horizon waiting for its approval in obstructive airway disease, and that is oscillometry. Your views on incorporating oscillometry in day-to-day assessment with spirometry, without spirometry, or in which situations? Supreet bhai.
You're muted, Dr. Supreet.
Thank you, sir. So we have got two types of impulse oscillometry. We know as one is called FOT, force oscillometry, and one is called impulse oscillometry. The difference is the different sine waves and the square waves they use. The impulse oscillometry has got two types like monofrequency and pseudo-random. So in monofrequency, we send waves at a particular frequency one by one, and in pseudo-random, we send all the frequency and measure impedance. So what impulse oscillometry does is it measures small airway obstruction. So though there are I know many people dispute it, but I use it only in the patients in which I'm not able to get a good spirometry, or spirometry is normal despite the high probability of a COPD in an elderly patient and in a small kids. Then coming to point, I know many people will say, why small airway obstruction? It is already seen. So I would like to make one point is, when we see an airway obstruction, 66% of airway obstruction occurs in the upper airways. That contributes 66% of airway obstruction. 23% is contributed by first to 7 zones. Those we are called as large airways. And the small airways contribute only the 7% of the small air, that is beyond the 8th generation, our bronchitis. So what happens is it requires more than 50% of small airways to destruct before they manifest. So impulse oscillometry, what it does is it picks up early airway, small airway obstruction. Because spirometry picks up only the large airway obstruction. So by the time you discover large obstruction, small airway obstruction would have already happened. So that is why in those patients, those who have spirometry, high probability, and a normal spirometry, in those cases, we advocate impulse oscillometry.
So that makes it pre-COPD. That doesn't make it COPD. That is the issue with impulse oscillometry.
And one more point is, sir asked, one marker which you can see in spirometry which can suggest small airways, we can measure SVC, slow vital capacity, which is also a surrogate for small airway obstruction.
No, may I differ, Supreet? SVC and FVC, there is a difference when there is severe degree of airway obstruction. Otherwise, FVC and SVC are quite close together. I had a paper on this in 1995. So as the degree of obstruction increases, the difference between FVC and SVC goes on increasing. So the difference between FVC and SVC depends on the degree of airways obstruction. So when you have SVC much larger than FVC, that will usually happen in patients who have got severe airways obstruction.
That's because the exhalation is slow. The air trapping.
So, sir, why it happens is because when we do forced expiration, the airway, there's a dynamic closure of the airways.
Yes,
but
exactly.
in SVC, when we do slow airway, the airways get open. So we have always the SVC will be more. So that is what recently discussed by Dr. He is working on Dr. Musileni from UK. So he was telling it is one of the surrogate for SVC. We can look at SVC in a spirometry for a marker for a small airways.
So it's, I would agree with Dr. Supreet. I think it's a fairly useful marker. It's not, we don't have a definite number to say that this suggests that there is small airways, because the small airways are the more likely to collapse when you have a forced expiratory maneuver, which is why it's useful. There is no number that you can say that this will tell you there is small airways obstruction.
So this is what
the other dispute I have with what you said, Professor Chhabra, is you define COPD based on spirometry, and then you say that you cannot use, other methods to make a diagnosis spirometry because it is defined by spirometry. This is kind of begging the question. So I think what impulse oscillometry or FOT does is we are trying to move the diagnosis to an earlier stage, and hopefully we will redefine COPD other than purely by defining obstruction based on spirometry alone.
Exactly. In fact, I had sent a communication that why are we insisting on 70%? We are missing that early diagnosis of COPD. That came back rejected. That this is what the consensus is right
and
now.
One more point.
I'm sure in another 2 or 3 years, GOLD is going to revise its criteria, and we are going to move to a multidimensional definition of COPD.
So one more point.
Yes.
Sir, one more point is impulse oscillometry. We know Chhabra sir will be talking about prediction values, I know, but there's a Sandeep Salvi sir had his lecture last year. I heard that lecture before coming to this. So he was telling that he has done a study in which says impulse oscillometry for spirometry, we need to have predicted values because of the age, sex, and ethnicity. But when they did a study, the impulse oscillometry, the variability is only 10 to 20%. So it does not require age, sex, and predicted values in impulse oscillometry. That's why they have got a fixed values. And it picks up the earlier. So that's why they are saying impulse oscillometry is going to be the future and predicting the early part of the
debatable because Saibal Mohatra and Sajal, they both have come out with prediction equations for iOS.
Yeah, I know that.
2 equations.
Yeah.
Right. So it's a settled issue.
next couple of years journey is going to be very interesting, where we understand more of oximetry and where we look at this multimodal, parameters in
Another
diagnosing.
webinar on iOS.
So, sir, what I use is, we call it CRP, like clinical, radiological, and physiological assessment. So clinically, radiologically, and P stands for physiological assessment.
But
So
I agree with Dr.
if I
Mohan
get
that
two positives, I usually start the treatment.
Dr. Mohan is absolutely right that we are wasting just too much time waiting for obstruction to develop in COPD. And that takes a few years to develop. So by the time the COPD is already, beyond any good response to treatment.
So, sir, small airways, by the time we manifest large air obstruction, small airways already have damaged. So that's why it's early to pick up.
And it's required to pick up small airways.
Criteria has to change.
So early COPD, yeah.
Great. Let's move on. Dr. Muliman, I wanted to ask you about this blood gas analysis evaluation in the OPD management practice. So you have a COPD patients with different clinical situations. I'll give you have a COPD with respiratory failure, COPD with type 2 respiratory failure, COPD with pulmonary hypertension. Do you do blood gases as a part of clinical evaluation in OPD? I'm not talking about ICU use. I'm not talking about indoor use of blood gases.
Not routinely. I tend to do it when I suspect this person may be somebody who's a CO2 retainer. When I'm looking for alternate problems. For example, you have a person with a COPD OSA overlap, which we've not discussed yet. And there, I have this obese patient who may have an OSA OHS and has COPD. In him or her, I may be doing ABG as an outpatient. It's very, very different from the inpatient situation. I may also do it on my first follow-up for a patient who was admitted and now is coming back for evaluation. But I would not do it as a part of routine evaluation of a person with COPD.
So you have a patient of type 2 respiratory failure, COPD with, say, PCO2 of somewhere around 60-65 with a stable pH. You have put these patients on home, say, BiPAP. This patient is on home nebulization therapy. Is a respiratory failure being managed at home, and he comes for follow-up. Do you have a habit of asking for routine ABG for such follow-up patients?
Sometimes I do. So when they're on treatment, I want to see how they've improved. The patient has insisted on going home early rather than waiting for these evaluations to be done in the hospital. Then I would tend to do it at the first follow-up, perhaps. Not as a matter of routine.
See, these patients who are in chronic respiratory failure and the disease is progressing, eventually they'll start retaining more and more CO2. So then the next step in our management will be whether to add a home NIV or not in these patients. So in that case, an evaluation with ABG is required to see how much CO2 has increased along with dyspnea, because then they become candidates for NIV. Apart from that, the first question on routine, if on routine follow-up in OPD, their pulse oximetry is showing a saturation of less than 90 because the disease is progressive. So one day it's going to go into respiratory failure. So if saturation comes to below 90% in a stable patient, then that's an indication for an ABG to decide whether the patient fulfills the criteria for home oxygen or not.
So when you're deciding about home oxygen therapy, when you're deciding about carbon dioxide and type 2 respiratory management, probably blood gases may have a meaning, but not otherwise, correct? And Chhabra sir, in the continuation, what is the utility of this 6-minute walk test in the COPD management?
6-minute walk test is important from two angles. One, it's a surrogate for diffusion capacity if you don't have the facilities for, so I call it a poor man's diffusion capacity test. Secondly, it tells us about the exercise limitation, because if we look at the MRC classification of dyspnea, then it is not actually dyspnea that we are measuring the activity limitations. In each of these 1, 2, 3, 4, 5, the word is I get breathless when I do this, I get breathless when I do this. So that is progressive activity limitation. So as an assessment of patient's activity limitation, a 6-minute walk test is very important. Secondly, the degree of desaturation that the patient gets, that is very important, because it will help us to fine tune his pulmonary rehabilitation. So before starting pulmonary rehabilitation, a 6-minute walk test is I would say an essential test before we start any kind of OPD or an inpatient rehabilitation program. It will not affect the patient's day-to-day pharmacotherapy, but pulmonary rehabilitation and then the impact of pulmonary rehabilitation. Because if the patient gains an extra 30 or 40 meters, 6-minute walk distance, that is an effective response to pulmonary rehabilitation.
And sir,
Let's remember
the
that a
distance.
6-minute walk test is not a measure only of lung capacity, it's also cardiac, it's also rheumatological. So it's a global
Sarcopenia.
assessment.
And patient motivation also.
Absolutely. Absolutely.
Great. Madhukar, Dr. Chhabra sir very beautifully spoke about the evolution of spirometers from those huge bade spirometers to those water dispensing machines to now a small handheld. What do you think is this future of this spirometry? Do you think this app-based or the small spirometers or the spirometers where you have even the small device given to the patients and doctors on the desktop can view their spirometer? Do you think this kind of devices and this kind of thing would be a game changer? Do you think this kind of devices would add really value to decision making, or it would add to nuisance where patients would report to you about daily changes in their fluctuations and would want probably answers from you? What do you see is the future?
Yeah, I see a kind of great prospects for these kind of devices in the future for the management of COPD. Why do I say this? I mean, these uh, digital spirometric devices and portable spirometric devices. These devices get easily connected with the phone through the Bluetooth or the computer screen with the and the data can be stored in the iCloud. Also, these devices are compatible with the medical electronic medical records. So this is very compatible. But over the last 2 years, what has changed these devices are now these devices are they get auto calibration. So now these devices are coming up which has the features of auto calibration. So where are we putting these devices in the present era of COPD? We are definitely not going to use these devices for the diagnosis of the patient, because for the diagnosis of the patient, we need conventional spirometry in a supervised condition where we can minimize the errors during the measurement. But these devices are good devices for the screening purpose. For example, if you're going to have a camp,
they're monitoring their home management. Yes, absolutely.
Centers, you are going to screen those patients, and if they come positive on the screening, then you subject those patients for the conventional spirometer at the lab. The second important point is these devices are important, as Dr. Chhabra sir was talking to us. I mean, if they find improvement in FEV1 at home, they are more encouraged and more compliant to attend a pulmonary rehabilitation program. And this has turned out to be, a game changer in my practice, because I have a pulmonary rehabilitation center at my clinic, and those are the patients who has the improvement on home FEV1. They would really come and be more encouraged to participate in pulmonary rehabilitation. Third is, uh, though we do not subject the patients, stable COPD patients, for the frequent spirometry, but these patients at home, even when they are stable, if they go on to check their FEV1, so sometimes they may come up that I have got this FEV1 which is less, but I'm still stable. Then I would subject those patients to the conventional spirometry to check this. And if it is the real problem that FE is going down, but the patient is stable, then it would make me think that these are the patients who can deteriorate in the near future, can have exacerbation, or can have a feature of what we call the rapid decliner. So these are the things where I am using these digital and portable spirometric devices. Thank you so much, sir.
Interesting. Indu, by any chance, any use of your old peak flow meter that we use for asthma? Do you find that peak flow meter helping you in any way in managing COPD, number one, and any biomarkers that you have in mind or would you like to monitor during your COPD management? Indu.
Dr. Indu, you're muted.
So yeah, peak flow meters I don't use in the COPD patients, but yeah, if you're talking about biomarkers, then yes, a CRP would help in telling us about the systemic inflammation. The other biomarkers would be, what blood eosinophil counts to look at, if the patient is T2 high inflammatory phenotype, then, adding an ICS to the dual bronchodilator would help. What are the biomarkers? I think these two are relevant. Other than that, looking for the comorbidities, then there are different, tests which we can do, like an NT-proBNP to look for the heart failures. But for a COPD patient, I think the blood eosinophil count and CRP. Pheno doesn't help.
Pheno, in patients who have got the so-called overlap or have an asthma component, and you're looking at T2 inflammation, then that is used.
Yes, definitely.
Especially with the approval of overlap for COPD, pheno is an important marker.
So if it's a smoker with the advanced asthma and you have a overlap, then of course pheno will help in guiding the treatment.
Because T2 inflammation phenotype is being now talked about, and dupilumab has already been approved for that. So there is some place for pheno, especially values like above 50.
But sir, again, when we are talking about the indications for dupilumab, the algorithm still says that, you look at the group E patients who are frequent exacerbators with a blood eosinophil count of more than 300, and the patient is already on the triple therapy. Then you give a dupilumab. So they have not mentioned pheno. I don't think they have mentioned
pheno as a marker of T2 inflammation, no? So that supports that.
Of course, yeah, sure.
Can I say something over this?
Yes, Madhukar?
Yeah. The trial with dupilumab has, that we have two famous trials. Those are randomized control trials for dupilumab. And they have not used pheno to identify TH2 phenotype in COPD. The reason, there are several reasons. One of them is, the smokers or the former smokers tend to have lesser pheno than the normal. So they have actually used blood eosinophil and the chronic bronchitis phenotype to decide that these patients are going to be, enrolled in the study and whether the benefits are occurring in them or not. So at present, we are not using pheno to decide on dupilumab in patients of COPD who is exacerbator phenotype. Thank you, sir.
No, but when there is a difficulty in differentiation,
I think this is the time for you to
COPD,
yes, sir.
Set of patients where there is always a doubt whether they have got a severe asthma or COPD. So to establish the asthma component, pheno is a useful marker in those patients. We're not talking about biologicals here, but in differential diagnosis of COPD and asthma. For example, if emphysema is there, that takes the diagnosis towards COPD. If pheno is raised, that takes the diagnosis towards asthma component in the diagnosis.
Sir, I would slightly beg to differ here. Pheno doesn't help in the diagnosis of asthma or COPD. Pheno only tells us that the patient has eosinophilic airway inflammation.
Exactly.
Kept in the mind that this is where the pheno is primarily being used for.
See, when we talk about diagnosing asthma in a patient who has got COPD, we look at the family history, we look at the IgE levels, we look at eosinophils and pheno. So it's not one parameter that is taken, it's a complete picture that is considered before we say that this is the asthma component. We'll treat the patient as asthmatic.
So again, when you have eosinophils in the blood, it's not a perfect marker for eosinophilic airway inflammation.
Yes.
There is a good correlation, but it's not perfect, which is why I think pheno still plays a role. The fact that it was not used as a marker in the trial for inclusion doesn't mean to say it's not a useful marker. Let's be clear about that. They have to choose something which is eminently reproducible every time, but we use it clinically all the time. We have a paper that shows that, a cutoff of 22 is actually very useful in the pheno to help you make a diagnosis of, asthma COPD, what we used to then call asthma COPD overlap. I have one more important point to make from a previous question that, we spoke about home monitoring of FEV1. It's important that when you put a patient on rehab, they shouldn't expect their FEV1 to get better.
Absolutely.
It's not the goal of treatment. So you need to tell them, look, this may not get better. So don't get worried about it. What we are trying to do is improve other things, your exercise capacity, what you can do. I remember Professor Martin Partridge telling us very clearly that, some of the questions you ask are not, what can you do or can you do something that you were not able to do previously? That's an important point. Can you do the same that you were doing previously, but more quickly and with less stops? Do you feel less breathless when you're doing it? Those are very important questions that you ask rather than go by a fixed number in a condition where you don't expect much of an improvement. And in fact, over time, they will decline. You are expecting that as a part of COPD. So let's not give them false hopes of saying FEV1 will get better. So that's an important. If they get better, wonderful. If they don't get better, let's not get too disappointed.
Absolutely. Home monitoring, home spirometry is not really the answer for COPD, especially in Indian scenario.
So pulmonary rehabilitation does not improve lung function. It only increases the functional capacity and increase the quality of life.
I absolutely agree that FEV1 doesn't improve with pulmonary rehabilitation, but it is a way where we can, and if the patient finds it, if they find some kind of improvement in FEV1, it makes a sense to, to tell them that it's going to help you, and the patient gets motivated.
Just to motivate the patient.
Yes, correct. Scientifically, I absolutely agree with both of you that pulmonary rehabilitation is not going to increase the FEV1 to a significant extent.
I just wanted to emphasize, Dr. Madhukar, that the patient shouldn't get disappointed that the FEV1 is not improved.
Absolutely.
That's an important point.
And doing spirometry is not easy. And if he doesn't do it properly, he'll get falsely low value and he'll get demotivated.
Yeah, this is why I tell that if the patient finds less FEV1 going down on home FEV1 monitoring, then the patient comes to the clinic and we subject them to conventional spirometry. And this is how the entire portable and digital spirometry practice is happening in Europe. So I believe there has been a separate section on this spirometry, which is going to be released perhaps around 19th on the COPD 2026 guideline. And maybe that is the perfect time we can have more and more clarity about this.
I'll just remind you that one of the important pirfenidone trials was completely negated because home spirometry was so variable they could not rely on it. So just junk the trial.
And even, sir, Gold now says that FEV1 or home spirometry screening should not be done only in targeted population, not for general population. That also Gold says. Screening PFT should not be done.
This is why.
So we've had very interesting discussion on spirometry on PFT, and I think it is the time for us to ask Krishna to come live. Krishna ji, darshan do. By the time I ask everybody for their final take-home messages. So I will ask, start with Dr. Chhabra sir for your take-home message by the time Krishna comes live. Chhabra sir.
Well, COPD is a big national program and we have to tailor our approach according to India's needs. Ideally, spirometry has to be done to establish diagnosis, but if it is not available, then we must use our clinical judgment because a lot of Indians, what to say about Indian, even globally, they are diagnosed without spirometry. So we cannot say that if we don't have spirometry, we will not diagnose. We have clinical sense, we have got an X-ray, we got physical examination, good enough to start treatment, ideally confirm with spirometry and do as per guidelines. Specific treatment as indicated, not overuse steroids, go by the gold guidelines.
Wow. Dr. Mohan sir?
The problem with spirometry is, not that it's not just not used enough. It's that the quality of spirometry is really very poor in many, many centers. So a concerted effort should be made to improve the quality of spirometry, train the spirometry technicians, and, spread the message that spirometry is a very, very important tool in our care of patients with lung disease, all kinds of lung diseases, not just COPD, that it has an impact in other diseases, including cardiovascular diseases and so on. But the quality should be ensured. And until that is done, you cannot rely on any spirometric reading that you get.
Absolutely. Thank you, sir. Indu, your views?
Yeah. So I feel that COPD being a heterogeneous lung condition, we should have a holistic approach towards management. And after diagnosing COPD through spirometry, symptoms, risk factors, we should definitely look at the comorbidities and the treatable traits and treat accordingly. These patients are really elderly, and just by saying that you have a COPD and writing a triple therapy or a dual therapy doesn't help much. I feel we can go beyond that. And in every follow-up visit, we can look for more than what we are looking for in the first visit. Like there's so much to explore, I feel.
Do something more. Perfect. Madhukar, your take-home message?
I absolutely agree with Dr. Chhabra sir, Murali sir, Dr. Indu. Everyone has put up the message very well, and I'll go in unison with them. Thank you so much.
Yes, Dr. Varuna.
The Chhabra sir and Mulli sir has told rightly, and spirometry is what we tell is the air movement, but all the other lung function tests to be combined to see how the lung actually works. So we need to get a complete picture to see the disease severity, the progression, and the treatment.
Perfect. Supreet bhai?
So I will say that spirometry should be performed in a structured manner. Bronchodilator reversibility should not be taken to start inhaled corticosteroids. That is very important because as LABA ICS is worse than LABA LAMA. And other thing, comprehensive management is important along with vaccination. We are not focused. Vaccination of patients in the season with flu and pneumonia and the other vaccination is very, very important to prevent the exacerbation, which can lead to mortality.
Great. I wanted Krishna to join in and I wanted him to give us some policy statement, some vision that Chest Council of India is to propose to the young chest physicians of a country so far as spirometry and COPD is concerned, but I think he is not able to join. So friends, thank you very much for your time, your presence. Your presence really means lots to us. It's only because of your presence we could do such fantastic program. 1800 and plus logins, and that's my CCI family is all about. We all always encourage each other by presence, by wisdom, by collective wisdom, as I would say. We had a great insight. We had a cross-country journey through the lungs of India. We moved from Delhi's smog to Bangalore's congestion, to Mumbai's paradoxes, to Patna's promise, to Dehradun's clean air, to Chennai's clinical discipline. And there is one takeaway today from me, and that is, trust me, COPD is invisible. It is invisible until you and me start looking at it. And PFT is our torch to this invisible. So let's not just treat breathlessness, let's measure it. Let's monitor it. Let's manage it in a far better way. So thank you all. And as I would like to say, let's keep breathing knowledge and share it generously. Thank you very much for
Agam. 3 cheers for Agam.
Sorry, sir, it's all
Very good.
Yes.
Thank you very much.
Thank you very much.
Thank you, sir.